All right. Good morning, everyone, and a very warm welcome to everyone today. My name is Purba Chatterjee, and I'm the Associate Director for Global Health Equity in the Department of OBGYN and the Institute for Global Health Sciences. And I'm absolutely thrilled and so very proud to introduce my fellow DrPH colleague, Dr. Funke Fasawe. Dr. Funke graduated with a DrPH from UC Berkeley in the fall of 2025, and she is currently the Global Vice President of Integration at the Clinton Health Access Initiative, CHI, as well as the Country Director for CHI Nigeria and the Interim Regional Director for West and Central Africa. As you can see, she wears many hats, leading strategy, partnerships, and teams that advance health equity across 11 countries. So quite a huge role there. And the title of Dr. Funke's talk today is Global Funding Cuts, Local Consequences, and Health System Strengthening and Workforce Resilience in African Countries. I would also like to welcome Dr. Mara Decker. Dr. Mara Decker is an associate professor at the UCSF Institute for Health Policy Studies. And Dr. Decker is also a UC Berkeley DrPH alum. And she will be facilitating the discussion after Dr. Funke's talk. And then we'll have Dr. Funke's talk, and then we'll have a facilitated discussion led by Dr. Decker, and then we'll end with Q&A at the end. And so with that, a very, very warm welcome to you, Dr. Funke, and over to you. And it's so great to see so many familiar faces, names here today. And please, I encourage folks to turn on your cameras. It's just nice to see, faces as we do this presentation. So if you can turn on your cameras, please do so. Thank you. Over to you, Dr. Funke.
Thank you very much, Purba, and good evening for those who are on this side of the globe, and good morning to those who are on the West Coast in California. Let me just share my slide very quickly. We can get started. So, are you seeing my slides?
Yes.
Can you see my screen? Okay,
yes,
so let me just make it
slideshow or presenter view. Yeah.
Yes, I will do that right. Sorry, I'm just trying to find the button.
Okay, if you go to the top where it says slideshow.
Yeah, the top.
Now
slideshow about right after design, transitions, animation, slideshow.
Oh, there. Okay.
Two more over.
Two more over. Yeah, there we go.
There you go.
And then you can go into presenter mode.
Sorry, they changed because it's
from the beginning.
This one?
You can go from,
okay.
Yeah, or from current slide. Yeah. Mm-hmm.
Okay, great. So, is it showing full now?
Yes.
Yeah.
That's perfect.
Okay. So, hi, everyone. Once again, thank you so much for joining this talk. I'm really excited to be doing this with you, Purba, and Dr. Mara, and everyone else at UCSF, and as well as partners that have joined. I would very quickly just talk through what have been the local consequences of the global funding cuts initiated by, of course, what had happened in January 2025 with USAID being shut down, and how is this really translating into health system strengthening and resilience in Africa. As Purba earlier said, I currently work with the Clinton Health Access Initiative, and she has done a good job of describing my role. So I'll just move quickly into the outline for my talk, which is really giving a quick background, high-level description of how we are feeling the impact, but also really importantly is what are countries doing, how are they responding, recognizing that this is probably the new global health order that we're getting used to, and what are we seeing as the way forward, and maybe just some personal reflections based on the work that I do on a day-to-day basis and the conversations that I'm part of as we know, the USG funding cuts is probably the most unprecedented shock that we've ever experienced in global health. And this came not too long after when we had experienced what was a major increase actually in a lot of donor funding for health because of COVID, right? Between 2020 and a little on to 2022. But then in 2025, we saw this drastic drop in funding for healthcare. Of course, it started off as what was supposed to be a freeze and rapidly escalated into a withdrawal, with a lot of awards being cancelled, a lot of programs ended immediately. But then there was also ripple effects of this, which meant several of the multilateral institutions, WHO, Global Fund, Gavi, even the World Bank, felt the effect because the US government is often the largest donor to most of all these institutions. And immediately, of course, there were massive consequences across the globe, especially in the continent here in Africa. We saw significant declines in the ability of many of our health systems to deliver services that had been heavily reliant on the US government support, mostly the HIV, TB, malaria, which, as we all know, PEPFAR was the largest funder of these services, but also maternal newborn health, some child health services, family planning, nutrition. These were also affected. We saw lots of women-led organizations having to basically closed down because they just couldn't be sustained. Many CSO organizations also had to shut down because they weren't able to continue providing services that they were providing. And HIV clinics that had been almost 100% run by PEPFAR started to report declines in access to services, in access to commodities, or even in their ability to be able to serve their target populations. And for many of our African countries, Nigeria included, you would see that besides the fact that there's high out-of-pocket payments by the population, so people have to actually pay for services, donors provide a huge chunk of program funding for many of our core programs, particularly for essential health services. And this is not because, governments don't want to pay or governments don't want to do their job, but there's also lots of financing constraints that our governments have to deal with, capacity constraints as well. And many of the African countries are really indebted, right? There's a lot of debt that is also crushing their ability to put more money into healthcare. And so this is just kind of explain even much more the impact that the sudden and abrupt end of USAID, US government funding reduction, and subsequently what we've now seen to be other bilateral and multilateral donors rapidly reducing their aid budgets, how it's affecting the capacity of our government to be able to immediately respond or to fill the gaps. We know now that the UK government has announced that by 2027, they're going to reduce the proportion of their GNI that would be going to aid. We also know that several of the European donors are having to reprogram, reallocate what used to be available for ODA. These are now being shifting into defense and, other areas. And all of that is also trickling down again to the replenishment that most of us might be aware of. Gavi didn't hit their 18 billion that they were targeting. Similarly, Global Fund also did not achieve their replenishment targets. And the implication of this is, they're not then going to be able to fund as much as they would have funded. And several low and middle income and low income countries rely heavily on Gavi Global Fund for sustaining services. And as we've seen in the news over and over again, we're seeing this translating to fewer rations, whether it's in humanitarian, fewer beneficiaries being reached through services, but also fewer services across the continent. So when we think about, really how have the cuts started to affect us, you can think of them in certain specific ways, right? So the first thing is just how, because of the ripple effect on the global health multilaterals and the initiatives, we're starting to see a narrowing of the scope because their budgets are tightening, and the demand is higher. The gaps are much higher than they used to be when there was PEPFAR or USAID. So take Global Fund, for example. They've just released the guidance for round 8 for funding. And within that, you would see there's a lot of emphasis now on prioritizing, right? Like in the past, they would have been more open to exploring new innovations, new drugs, new mechanisms, but there's not that much flexibility. Now it's really focused on what we know works and works well, what is affordable, let's really prioritize. There's also reprioritization, even existing grants, and revision of country envelopes. And there's a lot more emphasis now on accountability, integration, etc. Similarly, on the Gavi side, there's a lot of conditions now that are coming up about, maybe reducing the proportion of funding that is really focusing on health systems and really going back to core immunization, procurement of vaccines. Of course, RMNCH has been really affected. UNFPA, UN Women, they are not getting as much funding as they would ordinarily have. And for those who may know, UNFPA tends to procure most of the family planning commodities for majority of the countries in Africa. And we're starting to see a situation where family planning commodity financing is at a huge risk, and the ability to be able to expand the range of commodities that would be available to women in many of these countries may no longer be possible, right? So there's now the increased likelihood of consolidating these RMNCH platforms with others and so on. So overall, the constraining of the global health initiatives is also translating into countries having to increase their own counterpart financing, but also there's expectations of figuring out integration as quickly as possible, having more trade-offs in how we plan and all of that. The second big way in which we're feeling the impact is implementing partners, right? A huge number of INGOs, local NGOs. In fact, at the time when USAID was being shuttered, there was a huge target by, the USAID to transition a lot of its funding to local organizations. And what has now happened is we've seen a lot of organizations that have either had to close, or they've frozen hiring, or they've let staff go. They've had to reduce their staff sizing. They've had to consolidate geographies. For the INGOs, it's more difficult to have sub-recipients or subcontractors. And for some, they're just basically closing out their program. The impact of all of that is now felt in service delivery, because a lot of what the NGOs bring, the community-based organizations, is plugging the capacity gaps that our health systems have, whether it's in community the reaching the last mile, reaching the last child, really getting commodities to the facilities, ensuring that the data that is coming in is reviewed, is analyzed, is reported, the information is used, and so on. These are all areas where we're seeing a huge drop in the quality of the services that are being provided. In the third area, we see, if you look at the system pillars, we're seeing impact on workforce. So many of these donor-funded programs actually supplement what government does, right? So sometimes you would have, for example, payments for outreach coordinators, people who go and deliver vaccines in rural communities. A lot of the campaigns are funded by the donors. Mentor mothers for HIV, for example, oftentimes that was 100% carried by USAID and PEPFAR. And so there's been lots of community-led programming disruption on the health workforce side. Commodities is a big. We've had lots of stockouts. We've had challenges with just the ability to procure as much as is forecasted, and even delays in the logistics. Data is another critical area. particularly for HIV, TB, malaria, where a lot of the data backbone was funded and managed by the US government. And so that in the initial stead, when this whole thing happened, it was like many countries didn't even have access to their data anymore and all of that. Thankfully, most of that has been restored, but it was a huge system shock and a huge reality check for countries that we have to, really rise up, own our data, own our own programs, and be on top of all of that. And as I've previously described, we've had challenges to service delivery, coverage. We recently read in an article a couple of weeks ago about how in 2025, child deaths for the first time in over a decade were starting to go up, when we had previously been celebrating the persistent and constant decline in child death. But that doesn't mean that countries are just sitting down and, crying or doing nothing, right? Like, we've seen countries step up. Nigeria, for example, within a couple of weeks of the announcement, the parliament was quickly able to approve a $200 million supplementary budget to try and offset some of the USAID cuts, because an analysis of resource mapping that had been done for 2024 showed that the US government was contributing about $545 million alone in 2024 to the healthcare sector, right? And so the government approved 200 million for procurement of commodities. The Ghanaian government has started an African health sovereignty process initiative, where they're really pushing government ownership, government financing, and true partnership with donors who want to continue to support. Cote d'Ivoire, similarly, they've also had to increase their budgetary allocation, but also are reprioritizing and thinking about efficiencies in their program. And so different approaches that governments are taking to be able to address these gaps. And in terms of, the archetypes of response we've seen, first things first, when the freeze was announced and everyone was like, okay, it's a freeze, after 90 days it will be reviewed. The first thinking was, how do we quickly bridge the gap, right? So a lot of analysis trying to understand what would be affected, what would be disrupted, what can governments quickly step in for the time being. But as it became evident that this was going to be the long-term thing, we started to see governments reprioritize their budgets and really focus on life-saving essentials, right? So, for example, Burkina was able to reallocate about $7 million from a World Bank loan that they already had from trainings, and really focus that on procurement of commodities and strengthening their digital health systems. Or in Zimbabwe, where we saw them prioritizing malaria bed net distribution to the highest risk districts, as opposed to what would have happened in the past, where this would have gone to the whole country. The second archetype is also where we're seeing governments really focus on efficiency. So a lot more emphasis on taking each of these interventions, running the data, running the analysis, and asking ourselves the questions: how many lives, are we saving by doing what? Are we prioritizing the right interventions? Are we focusing on the right geographies and all of that? Should we be doing more campaigns? Should we be doing more case management? So Benin, Cameroon, are examples of where decisions were made that seasonal malaria chemoprevention, for example, was still very effective, and they were able to find ways to still keep SMC going, but achieve more savings by streamlining trainings, reducing duplication. The third archetype is in just really looking internally and saying, where can we mobilize and reprogram domestic resources? And, as I gave the example, Nigeria, for example, did bring 200 million to say, look, this is additional funding for health, specifically for procuring HIV, TB, malaria, to close the gap. But also Eswatini was able to reprioritize about $1 million within their budget, and also added 1.6 million from government directly to cover some of the treatment gap and laboratory testing gaps, right? And the fourth area is on data and analytics, to again focus on epidemiology, cost effectiveness, resource mapping analysis, kind of linked to the earlier point about prioritization. And I'm sharing this because I also wanted to emphasize that while a lot of partners have been affected, lots of NGOs, there's still a lot of work that partners are doing, even in their reduced capacity, right? Especially things like using data and analytics. It's lots of the NGOs on the ground that are supporting government to think through, where is this data? What can we do with the data? How do we quantify, doing all of the gap analysis? And services are going on. They may not be as extensive and as, as robust as they used to be, but the biggest, I guess, focus of our government has been to ensure that even within the limited resources that are still available, we're able to reach as many children, babies, women, and the most vulnerable with services. And so from everything I've said, what we've experienced and the steps that are being taken, what do we see as the way forward? I think the emerging themes really from the conversations that are happening across many of our countries are aligned around integration. So we cannot continue with donor-funded vertical programming, right? Most countries are really saying we have to figure out primary healthcare center delivery. We have to start thinking about platforms that tackle multiple diseases and can help us avert even more deaths. It doesn't necessarily mean that integration is always efficient, but being more thoughtful, intentional, deliberate about understanding that. And we're seeing that like Nigeria between last year and now has taken a huge step to integrate campaigns. So for the first time, polio campaigns, malaria campaigns, neglected tropical diseases, and vaccines, routine immunization campaign, including the introduction of measles, rubella, it was all integrated into one campaign, same training, one budget, same teams, and it was rolled out with a target of reaching over 103 million people, children included. We've done one half of that, phase one, in the northern part of the country, and the southern part is currently ongoing as we speak. And so more countries are really thinking about that. How do we combine supply chains? How do we have one supervision system? Before 2025 January, you had, there was malaria supportive supervision, there was family planning supportive supervision, there was HIV supportive supervision, give it different names. But now it doesn't make sense to continue to do that. Or you have different community health workers that are doing the same thing, but specific to each program. The second critical theme is domestic resource mobilization. We really need to move from aid financed health, as I had shown previously, how, a lot of African countries, over 30% of spending on health is from donors, to government funded. There has to be more domestic investment in health, and that would help us to absorb these shocks better. And so a lot of countries are now really looking at innovative domestic financing mechanisms, more conversations around sin taxes, health insurance coverage scale up, looking at how to leverage digital technology and the coverage, value added taxes. All of these things are being considered and discussed, and countries are taking the Abuja declaration of meeting 15% of their budgets again more seriously. Private sector, I think we've seen a lot more conversation here. There's the piece of one, can private sector help us to be more efficient, more cost saving, but also to reach more people and more effective? And there's also the conversation about what can we learn from private sector in the way public sector is managed and is run. So everything from outsourcing, performance-based contracts, and leveraging digital technology and innovations to enhance how we do strategic purchasing for healthcare in Africa. Also, we have localization. I mean, increasingly, there's that discussion about, we know, like, when you look at the average budget of INGOs, especially the USG funded ones back in the day, a huge chunk of the budgets really used to go into overheads. And at the end of the day, the amount that actually came to the beneficiaries was not as much. And so thinking more critically about local subgranting, capacitating government institutions to actually be able to implement better, embedding technical assistance within ministries of health, and more importantly, really leveraging community health networks. We've seen that successfully in the HIV space, and increasingly there's a big push, even by donors, to do more with local partners. And we're seeing that local partners can really get this work done. It might not be as sophisticated or as fancy, but services will be delivered and they do lead to better health outcomes. We're seeing more, interest by philanthropy to see where they can come in. While they may not be able to close the gap that has been left behind by the US government, effective altruism, you have like open philanthropy now called coefficient giving, give well, give directly, quite a number of these new philanthropies that really want to focus on impact, take specific gaps and see how they can support government to really push the envelope on those, pivotal ventures. All of that is coming up more and more. And so these are providing some bridge financing, catalytic capital, while I believe they give governments the room to kind of really figure out the fiscal space, which takes a bit longer, and be able to step up their domestic resource allocation for health. Lastly, we're also seeing a change in the way donors are funding, right? So classic example, the MOUs that the US government has now started to sign is really focusing more on government-to-government financing arrangements. So less about going through NGOs, but really putting money in government, but expecting more from government. And so governments bring their money, the US government brings their own money, they align around what they would invest in, what they would do, but they also align around the indicators of performance and all of that. So we're seeing a shift from project-based aid towards more partnership financing. And it's not just the US government, even other donors are taking a similar approach. There's a Beginnings Fund that was launched last year, is a very similar approach for maternal newborn health. And we believe that this approach really could be one way to also help governments to fast track institutional capacity by reinforcing national planning, budgeting, procurement, and monitoring systems. And so in closing, what are we learning overall? Funding cuts were not pleasant. It was a shock. It was painful. But I think from an African government perspective, and I've heard this across several governments that, I've engaged with in the last few months, it has forced a long delayed transition to country-led, fiscally grounded health systems. Like we've talked about this for so long, and it suddenly happened, and now governments have to deal with it. Integrated PHC is probably still what would be the most resilient for most countries where we currently are in our healthcare system. And it would be the easiest way for us to be able to better manage any donor withdrawal. Domestic financing cannot be, understated. Countries have to step up. They have to mobilize and continue to invest more in health in order to be able to manage what they prioritize, but also sustain services. Diversified financing is also important. While governments want to step up their domestic financing, they still have to explore partnerships with philanthropy, with private sector, pooled funding, an array of funding opportunities that exist. And last but not the least is just country ownership. And it's really important, even if donor aid comes back at the same level as it was pre-January 2025, I think most African countries want to be in the driver's seat, and not be in the driver's seat on paper, but really be the ones setting their priorities, aligning technical assistance, and determining what the agenda should be for their respective countries. And so for us, going into the future, as I've said, it's really to put PHC at the center. There's still quite a bit of advocacy and work that has to be done to get governments to see health as an economic asset and not a liability, and not to assume that, oh, somebody will pick up the slack for my people. We have to be able to leverage philanthropy and these new models strategically. It's no longer, just money in the system, but like these should be used to catalyze and stabilize services. Delivery ownership, we have to strengthen our ministries at all levels, whether it's at district level, at national level. All levels need to be strengthened, and local NGOs also need support to become the backbone of our delivery. We also have to really think about private sector. They have a big role to play, and they want to play in this sector, right? So I think countries increasingly are looking at how can we bring private sector in. And last but very, very important, and this is where I think we've always kind of dropped the ball, is countries cannot afford to neglect governance, coordination, and accountability. We, more capacity building around how we plan, how we coordinate, and most importantly, how do we measure outcomes and tie those outcomes to financing? Because increasingly, if governments are putting their money in, you would hear Ministry of Finance would say, well, I need to know what we're buying for every dollar that we're putting into health, right? And so we need to start to speak that language. What's the return on investment? Every time we put money into immunization, what does that really translate into, both from a health perspective, but also from an economic perspective? And so on that note, I just want to thank you all for listening. And yeah, I'm happy to take any questions from here.
Great. Wow. Fantastic. That was such an amazing presentation, Dr. Funke, such a comprehensive overview of the impact of all of the challenges that we've been facing since January 2025, and how local African governments are kind of, stepping up and doing things differently. So before I hand over to Dr. Decker, I just wanted to mention that these talks are part of UCSF IGHS's Global Partner Spotlight series, and it's really what we're trying to do is bring together voices from really diverse settings to share insights, challenges, and innovations, like you've done today. And this is by far the most popular one with 120 participants, so it's pretty amazing. So over to Dr. Decker for a facilitated discussion, and then we'll end with Q&A.
Well, thank you so much. And just to reiterate what Purba mentioned, what a delightful and insightful presentation. Not only did you give an excellent overview of the current situation, but I loved so many of your suggestions of a path forward, a way to really increase the ownership at the country level, and to use this unfortunate time as a time for some course corrections as well. So I'm going to start with a couple questions, but I strongly encourage, we have 121 people and I'm sure they have fantastic questions. So two options for you in a minute. If you would like to just go off mute and ask your questions, that's great after I start with a couple, but also you're welcome to put your questions in the chat. Purba, I think, will be monitoring the chat, and we'll be sure to be checking that as well. Dr. Fasawe, it's fun to call you Dr. Fasawe. Let's maybe start with, you mentioned a little bit about these different types of ways that you can have programming, these projectized programming versus country-led versus partner-led. And also kind of these at the local level. Could you talk a little bit or give an example of what those different structures would look like?
Sure. So I think the one I gave an example of is the recent US government MOUs that are being signed with governments, right? So we're shifting from the past where you would have USAID release a funding call and big IPs, implementing partners would apply, huge budgets, huge plans. But for the most part, even though you would consult with the government, a lot of it was really people from the US and local collaborators designing what they think would work. And then USAID gives that project to the NGO, and the NGO then starts to implement. But what's happening now is the government and the US government will jointly agree on what the priorities are. It has to align with what the government has determined. So take Nigeria, that has moved towards the sector-wide approach. Nigeria is saying we're doing one plan, one budget, one M&E system. And so whatever you want to do has to fit within that. One of them is being maternal newborn health. And so it's no longer the days where you just decide in DC or in Virginia and you come and tell us what the problems are and what we should focus on. But it's now governments who say, yes, we want PrEP because we've done the analysis and we know that pre-exposure prophylaxis would help us reduce HIV. More importantly, the accountability. So again, in the past model, the NGOs were the ones who would report to donors. They would report to USAID, and they can report what they like. For the most part, we want to believe that we were reporting truthfully, but most governments didn't always have visibility into where those data came from and what they were reporting as achievements. But now it's governments who would be measuring through their own surveys and saying, yes, we're seeing a decline, we're seeing an increase, whatever it is, but at least governments are really leading that process. So that's one model we're seeing. The second model we're seeing is also where now for donors are saying we will fund NGOs, but only after there has been an in-country process of aligning on what the program this design should be. So that's an example from the Beginnings Fund, right? Where Beginnings Fund says, I will fund, or MasterCard Foundation, but we need to see that there has been a consultative process. Everyone has designed this. All partners are on the table, including government. And then the government takes the lead on selecting which local partner can implement that and so on. So, I think the shift is really increasing accountability and ownership. There might be some compromise in terms of capacity to deliver initially, but it also then forces government to quickly upskill, because in the past, government would just say, well, this IP is handling it. They didn't need to have a statistician or an economist. But now, if I'm going to be measuring life saved, if I'm going to be measuring cost effectiveness, then I need a health economist. So I'm going to have to hire someone who can do that. And that is capacity that is retained in the institution. So I don't know if I answered your question, but those are like two examples of the shifts we're starting to see in the donor financing that we still have.
No, that's fantastic. Thank you. And a follow-up question with that, when we're talking about financing and we're talking about, and I see a question is coming, but I'm going to ask this one first. When we're talking about financing, it seems like there's these competing issues, right? That on the one hand, countries need to step up and truly invest and recognize the importance of health. On the other hand, they're having to suddenly pivot and provide bridge funding. And then finally, you mentioned the challenge when you already are dealing with debt. So I guess my question to you is, what do you think is really feasible or sustainable for these countries in terms of their financing?
So I think, CHAI and a couple of other partners similarly are doing these types of analysis. But what I think governments are increasingly learning is, the first thing has been to do a quick gap analysis, right? So just taking stock of what was being funded by who. You'll be surprised that many of our governments didn't have that much visibility. So going through a resource mapping process is like just understanding who was doing what. And then further looking into what each person was doing, whether government, whether donors, and saying how much of this was a nice to have, how much of it was a must have. So there's this whole reprioritization going on. And I think what we've seen is there has been quite a bit of waste in the system. And even with limited resources, we could potentially achieve the same level of impact or just a little lower than what had been in the system, right? So I think where we are now is even just driving efficiencies. So across all our countries, it's been, I gave the example where Burkina Faso said, look, we're wasting money on trainings. These are trainings that if we were to consolidate, we would unlock $7 million that could be used for procurement. Had there been no USAID shutdown, you would have had the same 10 trainings for the same thing happening, right? But now we're being forced to look into that and to really be intentional. So I think the way governments are approaching it is not to suddenly assume that they're going to replace what USAID left with, but to actually say, maybe we've been too wasteful because we had all of that support. How do we first of all start by driving efficiencies? And surprisingly, I believe many of our governments are seeing that even with limited budgets, they could have been doing a lot of what they were getting. They just hadn't paid enough attention. So they're being forced to do that. But that said, you can do that to retain your current level of service delivery. Most of the services are not where they ought to be. We're still below coverage in many of our programs, right? And so while the immediate focus has been drive efficiency for the first year, there's still all of the conversation about, how do we continue to pay for this year on year? And that's where the discussion on financing from domestic budgets becomes important. And so governments are also working more closely with their ministries of finance to say, what are the tools, what are the financing mechanisms that are available to us to start to think about? So we're also hearing about debt swaps now. Some countries are starting to look into that. Gates Foundation is supporting some thinking around debt swap. How do you make these debts cheaper for countries so that the savings can then be put into increasing the budget envelope for health? But it's not a one-day solution. It's going to take time. And that's why I believe many of our countries know that we still need donor support, but it cannot be in the same model that it was pre-January 2025.
Great. So there's some questions coming in. There's one in chat, and then we'll go to Amanda and then Bridget.
Right. I'm going to read the question in the chat to you in case you're not seeing it. So this is from Allison Tatarski, and I'm hoping that I'm interpreting it correctly. She says, thanks for such a fantastic and thought-provoking talk. What are you hearing from your partner governments about their commitment to health equity? As in the US, it's often the CSOs and NGOs in Africa that reach the unreached, where government is less focused or less invested.
Yes. So what we're hearing, our governments care about health equity first and foremost, right? And that's why even in the prioritization conversations, they're starting with the most vulnerable, the most neglected, those who cannot afford. Unfortunately, in Africa, we don't have such a hugely developed health system. So you still have quite a number of people in the highest income quintile who are buying their healthcare or who are covered by private health insurance. And you have a huge chunk, take Nigeria, where the multidimensional poverty rate is 62%. There are people who are not covered by insurance. There are people who cannot afford 3 meals a day, right? Those are the people government is really thinking about. So I think everything we've heard and I'm hearing is that health equity comes first and foremost. It's also a political thing. You don't want to leave one region behind. You don't want to leave one group behind, because this also plays on their votes, right? In Africa and in the US, everybody cares about votes. So for governments, health equity is important. They're prioritizing the most vulnerable, the most, unreached populations, and making sure that as much as possible, the most basic essential services are sustained and at a high coverage. And that's why there's a lot more conversation now about scaling up health insurance, whether it's community-based or it's government subsidized and so on.
Great, thank you. I'm going to turn it over to Amanda.
Hey, first of all, Funke, thank you so much for the fabulous talk. I expected no less from you. I would love to also have you speak at Stanford. So I have 2 questions for you. The first is just around the fact that there are so many countries that are experiencing a severe shortage of human resources for health, and especially with the brain drain. And so, you spoke about how training oftentimes, in some cases is, about reducing the duplication and unnecessary trainings. But in the research that I've done, I've also found that training can really be an incentive for healthcare workers, maybe partly because of the per diems that they get. But I'm curious whether you have any information on how that may have impacted motivation or morale of healthcare workers, especially, when they were already so overburdened, and now the situation is such that they have to do even more with less. So that's the first question. And then the second question is just also based on my experience, and this is really solely in Zimbabwe, where local subgranting was tried. But the subgranting actually went to the implementing partners rather than the government. And so that actually didn't work that well because of course, money is power. And so it seemed like the implementing partners still really had the power. And so I'd be curious whether you can provide some examples of where that was done and that it worked well. Thanks.
Sure. So maybe if I quickly answer Amanda and then take the next question. The first question about morale and impact on health workers' motivation. I don't have data that I can quote to say how has this impacted morale. What I know for certain is for staff who were in the system funded by government, they are still working, right? Where we're seeing challenges is with ad hoc staff that US government had to pay to optimize services, mostly around quality or for equity, right? So like key populations, reaching key populations and the rest. And so many of the implementing partners had to hire a lot of, additional laboratory staff or additional patient navigators. These were all 100% paid by the US government. And so with the end of the funding, a lot of these people have left the system. But what we're also seeing is, they've left the system, they don't have jobs, right? So it's not as if they're being absorbed elsewhere. And in some countries, Ghana is one that I'm very certain of. A lot of these people have been absorbed back into the system by the government. They're not being paid at the same rate at which PEPFAR was paying them, probably much lower, but they're happy to continue to use their capacity and their knowledge to ensure that services continue. So I feel like it's one of those situations where you create a behavior or a habit because of a wrong incentive, right? We've seen that in polio. But everybody saw what the effect of this was. And so it was really about I get what I can get and remain useful and relevant to the system. And so where governments are absorbing some of the capacity, people are going back to work and they are taking pay cuts to continue to have a job and to continue to do their work. That said, there are people who didn't go back to work. So maybe they're hoping things will go back to normal. We don't know. But I also know that many governments are also looking to really control the sort of salary disparities that existed between what INGOs used to pay and what government pays, so that if this type of thing were to happen again, people would still be able to work and not be motivated by high salaries. To your second question about examples of sub-granting to government, so there are good examples where this is working really well. Nigeria specifically, Lagos State has been a sub-recipient of Global Fund funding for the past 2 cycles. And this is money that goes directly to the government. They had to set up a grant management office. They had to undergo lots of training, hire a couple of people who would manage. And these are all government staff. Reports like every NGO reports. And, it was a learning curve, but they're performing very well. I think what we're also seeing, there's a swap coordination office in Nigeria, it's under government, even though it's kind of managed like a private entity. Similar principle is making sure that it's staffed by very qualified, experienced people who can operate and function at the same level as NGOs do, but these are people who are from government, right? So I guess the main difference is you then have to equip them. They have to have the same, they need to have access to internet, to phones, to printing, to be able to function well and be productive. And that's where I feel many of our governments are going to have to step up. It doesn't mean it will be 100% perfect. There's a lot of upskilling that needs to happen. But if we don't start, we would never get there.
Thank you. So we have a question from Bridget, and then there's two more in the chat. All right.
I was going to do the opposite. I was gonna take a chat person first, but we can let Bridget go. That's fine.
Great. Whatever. I'm happy with either. I really liked your talk. Thank you so much. This was interesting. We have a lot of points of commonality. I'm also a fellow Berkeley DrPHer, and I was recently a localization advisor at USAID as recent as last year. So I was working on some of the backwards internal systems to shift that system to actually be more ready for those, shifts to localization. But my question really is something you mentioned, and I'm hoping you maybe have more thoughts on it, is this idea of pooled funds. And I don't mean like how the US government is talking about their new idea of pooled funds, but I mean governments setting up their own pooled funds and what that could mean for kind of distributing resources and distributing how programs are being set up and even that integration aspect of programs. And curious of your thoughts on it and ways to determine like maybe a readiness or an applicability or utility of this type of setup for funding.
Yeah. So, I mean, again, I'll quickly use Nigeria as an example. There's an initiative under the SWAP approach that we're taking where they're now looking at TA alignment and basically getting the current donors that are still funding to pool their funding and trust government to be able to better identify and define priorities, but also assess capacity of the existing NGOs, whether local, whether international, and determine who's the best NGO to provide TA, right? So we're seeing that as one approach. So donors are open to trying that. They are all putting their funding into a basket, the BHCPF or the World Bank Hope PHC loan, and allowing government to decide which type of TA do we need and who provides that TA. And then it's government who will contract TA providers and say, okay, you X NGO, go and work in 2 districts, and these are the KPIs that we want you to deliver. So that's one example we're seeing. I'm aware that in Benin, they did something similar with community health workers where different donors came together and put funding together, and it was the government who led the whole community health worker strategy, figuring out how many health workers they had to recruit, where they were to be deployed, and all of that. That's one pool mechanism. But there's also the pooling where, take a country like Nigeria that has decentralized healthcare, where for procurement that is often centralized, we're now having conversations with states to say, can you all put in a percentage of your monthly allocations into this pooled funding so that we procure commodities for the whole country and we can continue to ensure consistent availability? Because we know there's a risk that if every state had to procure, some states would do it well, some wouldn't do it well. And then you start to get into the conversation about equity, who's reached, who's not reached. And so we're currently testing an approach where we would be pooling funds across state governments so that we can have pooled procurement managed at the national level.
Thank you. And we have several more questions in the chat. I don't think we'll probably get to all of them. But I want to follow up with one from Dillis Walker asking, in this new world order for global health, how is this role of in-country and external academic institutions evolving?
I think that's a great question. Just very quickly, and nice to see you, Dillis, is that what we're experiencing is more partnership, really. It's, we're moving away from the days where the external academic institutions were pretty much getting all the jobs and doing all the data work. And now I'm seeing a case where most countries are actually looking for local academia, and then local academia can decide which external academic institution they would want to support them and build their capacity. So I think the main difference right now is that because countries are taking charge of identifying TA needs, countries are putting their own academic institutions first, but also knowing that many of the academic institutions still need support to get to the level. Many of these academia are also reaching out to external partners for support. It's probably just not at the same level as where the external was the prime. Now it's the local that is the prime.
Great. And then I think this will likely be our final question from another person online who also appreciates your thoughtful analysis and is wondering if it's too early to know how funding is flowing through to subnational local public health systems through national plans, especially in countries that are more decentralized in their structures. Do you have any sense of this yet?
That's scary. So, yeah, we've been doing a lot of resource mapping, expenditure tracking, but that's the most difficult type of work to do in our countries because of the lack of data, lack of transparency of data, and I would also say some politics around increasing visibility into funding flows, right? So, in several countries, Ethiopia, Zimbabwe, Nigeria, Malawi, we've successfully done a lot of that at national. But increasingly, it's becoming, with what has happened now, it's more important to try and do it at the local level, at the subnational level. So I would say it's not as robust as what we have when you look at it from the national, but I'm aware that work is now being done to really map funding at subnational and even do like expenditure tracking, which is much more challenging to do.
Great.
Oh, Prabha, are you coming on or am I?
Yeah, no, I think we can wrap up. There's no more questions, and you've already addressed the final one. So, yeah, well, thank you so much, Dr. Fasawe, for an excellent talk and great discussion as well, Dr. Decker. Thank you, and I hope everyone has a good rest of their day. Thank you.
Thank you for the opportunity, and thanks, everyone.
Okay.
Thanks, bye.
Bye-bye.
Bye.
Bye. Thank you.
Bye.
Well, Funke, as people leave, delightful presentation. I did have like 300 more questions for you, but I wanted to honor the audience in the room. And I agree, yeah, Amanda will get you to come